First question, describe routine prenatal care. Be sure to include. So the first one is appointment schedule. So a pregnant woman should come in monthly when they are at 28 weeks. This switches over to 2 weeks when you reach 36 weeks. And then finally, when you reach 40 weeks, you're going to go in there twice until delivery. So I'm going to go by through the weeks where they're doing a couple of tests and the specific assessments that they're going to do. So starting off with week 7, this is the first, usually like the first appointment that they do to date the pregnancy. And this is also where they could look at the ultrasound and see the baby, and you could see the heart here within 4 to 6 weeks, but it's not as accurate. The certain questions for this appointment's important because this is your very first appointment and they need to have your history. So first is the current pregnancy. What's your menstrual cycle typically like? Your sexual history, if you're using any contraceptives, if you have or had any signs and symptoms of pregnancy, or if you haven't had any, or if you had any discomfort. Next is medical history. So if you have any chronic or acute illnesses, along with surgeries, allergies, any childhood diseases that you might have, and also the immunizations that you do have. Next is family history. So if you have diabetes, that could indicate if you're going to be prone to getting diabetes in your pregnancy. If you have any cardiovascular, genetic, multiple gestation histories in your family, along with the health of your previous children if you do have some. Next is they're going to look at the risk to see if you're at higher risk or at lower risk. So the higher risk patients will include if you're below 16 and if you're above 35 years old. And so also the history of having a previous stillbirth or previous neonatal death, along with preterm, gestational age, or if you're Rh sensitized. So that's for week 7. So now going into week 10 and 13, this is genetic screening. So they could look at the nuncle. So this is also looked at specifically, or like around 10 weeks. So it looks at the fetal neck to see if it's larger than normal, and this could be associated with trisomy 21, some sort of heart disease, congenital heart disease, or any other possible anomalies that could happen to the fetus. Along with chronic villus sampling, this is 10 to 13 weeks, and so they go into the actual cornic villus tissue and they aspirate fluid, which is about 10 to 25. So this is more invasive. So you want to let the parents know that this can hurt the fetus, but these are for people who want to know for sure, or if it determines that they're going to keep the baby or not. So next ones are the second trimester genetic screening. So this is about week 14, week 16. Triple screening could happen here. So it looks at the different levels. So AFP, HCG, and estriol. And this can indicate if they have any neural tube defects, if they have abdominal wall defects, Down syndrome, or trisomy 18. Moving on to week 15 and 18, they could have an amniocentesis where they go directly to the amniotic fluid and aspirate to see if this fetus does have any other anomalies. And again, the fetus is more at risk for injuries, but this is for parents who wants to know, and if like I said, if it's determining them keeping the baby or not. Week 18 through 20, these are more routine ultrasounds. So the fetal growth, where the placenta is, they could look at again at the fetus if there's any anomalies there. They could see how big the fetus is, and they could also do an amniotic index. And so they do what they do is they do quadrant-like, and they look at the empty spaces and they look to see what the size is there. And they all add it up. And then moving on to week 23. This is the glucose load test. So this is the first one. What they do is they give you 50 grams of sugar that you take in. So it doesn't matter what you had before, but when you're waiting for this, you don't want to eat anything. You don't want to exercise while you're waiting. You don't want to smoke. So if this is greater than 140, then you have to come back for the glucose tolerance test. And so you come back at week 24 to 25 to take this test. And so this test is longer, unlike the first one, which was 1 hour. This one is going to be 3 hours. And so within each one, they're going to check your test. So they're going to give you 100 grams of sugar, then check it every hour. So the first one, if it's greater than 180, and then the second one, if it's greater than 155, or the third one, it's greater than 140. So for you to be considered that you do have, if your glucose levels are high, then you have to test two levels have to be abnormal. And then finally, for like one of the bigger tests that you do, which is at week 28, you see if the mom is Rh negative, then you would give them Rogaine at this point. Question number 2, describe the different types of hypertensive disorders that can occur in pregnancy. So first one is preeclampsia. So what is the physiology of this? It's high blood pressure increased with the amount of protein in the urine. So this occurs before 20 weeks. And so the blood pressure could reach up to 140/90 with urine 1 to 2. This is for mild. And then for chronic preeclampsia, it's 160 to 100, and urine could be at 3. Both needs to be taken 2 times and 4 hours apart, so they could be diagnosed with preeclampsia. The possible outcomes for mom and baby, so fetus, the baby could come out hypoglycemic, hypothermic with an increased amount of bilirubin, placental insufficiency, SGA, hypoxia, and prematurity. Now mom, she could have edema because there's just so much fluid shifts in the extravascular space, low urine output because of the vasospasm that decreases the blood flow, cerebral vasoconstriction, which is poor perfusion to the brain, so headache, altered level of consciousness, visual disturbances, nausea, vomiting, hyperflexia, and clonus, and they also have a chance for seizures and cerebral ischemia. Next question is the possible treatments for preeclampsia and the risk for these therapies. So magnesium sulfate would be given for 24 hours. So what you want to do is frequent sign and symptom checks to see if there are any medication side effects. If you reach level 8, that's toxic levels. So for the mom, the side effects are decreased respirations, reflexes, and decreased urine output. For baby, there's a sedating effect. So if the baby comes out of the womb, they could be very lethargic. This could lead to eclampsia, which is seizures. So what you want to do if they do have that is you want to make sure their environment is safe. You want to make sure they have an adequate airway and there's oxygen available. You want to monitor time and duration of the seizure. And then when the seizure is over, you want to give the appropriate medications. How would you care for the mother who has preeclampsia? So what I would do is I would educate her of the signs and symptoms, when to come in, so they can detect it early, which means better outcomes for her and for her baby. What you want to do, if she is at the hospital, bed rest, left side laying position, because this increases the uterine perfusion. You want to give a high protein, moderate sodium intake diet. You want to give steroids for the baby if the lungs are immature. Next is another hypertensive disorder is HELP. So the physiology of this is that, so HELP stands for the things I'm going to say. So hemolysis, so where RBCs are broken down because of the damaged vessels. Next is elevated liver enzyme. So HELP, there is a liver there's a liver involvement here. And so next is low platelets. So it's low because due to the damaged blood vessels, there's not enough circulation, and they're just going everywhere else. And so, like I said, there's a liver involvement. before the hypertension, or sometimes there could be lack of symptoms, so it's harder for it to be diagnosed. So if the liver does rupture, this could mean fetal demise and also maternal death. So possible outcomes for the fetus: intrauterine growth restrictions because of the decreased placental flow, asphyxiation, placental abruption. So they have a risk for hypovolemia, hypotension, and some sort of platelet dysfunction. And also they have a really high chance for premature birth. Now for the mom, she's going to have some epigastric pain, right upper quadrant pain, nausea, vomiting, and she might have some flu-like symptoms. So for treatment, you want to treat what's missing. So blood transfusions for the damaged RBCs and the low platelets. When you're delivering the baby, make sure that you give steroids because of the immature lungs. Also, magnesium sulfate could be given within the 24 hours. And again, you want to make sure that she's not getting toxic levels and look at the side effects of that. So again, mom, decreased respirations, reflexes, decreased urine output, baby sedating effects when the baby is born. It could be lethargic. How would I care for this is I would check the fetal heart rate. I would stabilize the patient with appropriate medications, fluids, and blood products. And if needed, I would prepare for a C-section or an induction. So the final hypertensive disorder that I will be talking about is DIC. So the physiology of this is that there's an acceleration of the coagulation system where clotting and bleeding is happening, where it shouldn't happen at all. So the vessels narrow and there's breakdown of fibrinogen. And so what happens is that for the baby, the outcomes for the mom and the baby. So there could be fetal distress, and the baby needs to come out like right now. There could be a stat C-section. Mom, bleeding from puncture sites, incisions, mouth, nose, gums, anywhere else. There could be an immune response because some of the fetal products are entering the mom's bloodstream. Possible treatments here is, again, taking the baby out if needed, the blood products to replace what was lost, and then heparin. What would I do if I'm taking care of this mother? You would insert an IV, monitor the vitals, fetal heart tones if the baby is still in the womb. You want to administer an oxygen mask, give appropriate medication, and blood products. Okay, number 3, discuss the physiology of newborn jaundice. First, differentiate physiologic from pathologic jaundice. So physiologic jaundice is more common in healthy newborns or near-term newborns, and this occurs after the delivery. This is when the baby, there could be an ABO incompatibility, or the baby is solely breastfeeding. This is a milder form of jaundice and it doesn't really require a real intervention, but this baby could go out to the sun and have some sun time, and this will decrease the amounts of bilirubin on the surface. And so pathologic jaundice, this occurs in the first 24 hours and it could go on as long as 7 to 10 days. The bilirubin can increase more than 5 milligrams per 24 hours, while the conjugate is less than 2 milligrams. So for both pathologic and physiologic, the bilirubin is seen on the skin at levels of 5. Next is include all risk for development of jaundice. So first risk is hemolytic disease, which is ABO and the Rh incompatibility. So if the mom is type O and the baby is not, she has anti-A and anti-B antibodies, which then could attack the fetus. And so then next is polycythemia. So there's an excess amount of RBC floating in the system that makes it harder for the body to excrete excess amount of bilirubin. G6PD deficiency. This is seen more of Asian descent babies. And then finally dehydration and poor feeding, because since you're not excreting it, it allows for it to stay in the system. Next is all possible treatments for jaundice. So phototherapy can be used. So these are ultraviolet lights. Ultraviolet rays that can change the bilirubin at the skin level, and it turns into water soluble state where it could get taken out. So what's important here is eye protection for both nurse and baby. You want to look at you want to do frequent billimeter checks, make sure the baby is comfortable, frequent temperature checks, and you want to promote feeding. So this could aid in excreting that bilirubin in the urine and the feces. And then if it's an extreme amount of bilirubin levels, you could do an exchange therapy. So this is where the baby's blood is taken out and then the donor blood is taken back in. Taken out and then taken back in. Finally, it says include the goal of treatment of jaundice and the potential outcomes for jaundice is not appropriately treated. So the goal of the treatment is to decrease the amount of bilirubin and have the same ratio between albumin and bilirubin, so there can be enough conjugate to bind and excrete the bilirubin efficiently and effectively, so the baby doesn't have jaundice anymore. The potential outcomes, if it's not treated correctly, is acute bilirubin encephalopathy, where the bilirubin exceeds binding capacity of albumin and it causes changes in the basal ganglia. So this is reversible if it's caught, and one of the first signs is ototoxicity, along with floppiness or muscle rigidity, poor feeding, and very high-pitched cries. And next one is kernicterus, which is an extreme version of this, and when you reach this point you can't go back. So acute bilirubin encephalopathy, you can go back. For kernicterus, you can't. It's non-reversal and it has long major effects, so cognitive effects, learning, sensory. So the bilirubin can get up to 25, and so this stains the brain tissue. Yeah. Question number 4, describe fetal monitoring. And so the first question is, how do you interpret a strip? Be sure to include normal as well as abnormal findings. So when you look at a strip, basically what it's looking at the baby's heart rate along with the mom's contraction. So the X line is measured in minutes, and then the Y vertical line represents the fetal heart rate. And so within each red line, it represents 1 minute. And the baseline looks at the average of the baby's heartbeat per minute. So, and then the uterine contractions, the mom's contractions, are shown at the bottom, and together it shows the heart rate along with the contraction and how the baby's doing with that. And so the normal findings are fetal heart rate is between 110 to 160 beats per minute. There could be a moderate variability, no late or variable decels. Early decels and accelerations can be present, or they don't have to be there. So abnormal is fetal heart rate is below 110 or above 160. So there's absent variability and there's recurrent late and variable decelerations. Next question is, when is it appropriate to use intermittent versus continuous monitoring? So continuous monitoring is for higher risk pregnancy. So this includes twins, preeclampsia, or any hypertensive disorders. If a baby is SGA or LGA, gestational diabetes, cardiac acquired conditions, or any sort of substance abuse. Intermittent is for lower risk pregnancy. So this is if the baby's term, normal size, if the mom is healthy and no other complications throughout the pregnancy. And so next question is, given high risk conditions, what variations might you anticipate seeing a monitoring strip that requires you to identify the conditions that would result in fetal heart rate changes, along with what nursing interventions would you perform based on different types of fetal heart rate changes? So first, starting off with variable decel. So this is cord compression. What you could do is you could move the mom to increase oxygen, and if this keeps getting worse and worse and worse, you could go to a C-section. Um, Benign variable decels is when decelerations last 45 seconds if there is an abrupt change from end to baseline. The baseline doesn't increase at all and variability doesn't decrease. Severe if it's greater than 70 beats per minute or 60 seconds or more. It's slow return to baseline and it decreases in variability. And so the worst is when you combine variable to late decelerations. Next is early decelerations. So this is head compression with vagal stimulation. This can mimic contraction, and this is normal. This is a normal variability. This is okay. Next is accelerations. This is oxygenation, problem with oxygenation. This is normal and can go throughout labor and delivery process. Typically, it's 15 beats per minute, lasting about 15 seconds. Again, this is normal also. Late decels, this occurs during the rest of contractions. So if it's good variability, then you can keep an eye on it. But if it's not, then you have an issue in your hands. This can happen because of placental perfusion, twin-to-twin transfusion, post-state because the placenta is getting old, hypertension, so preeclampsia, DIC, maternal disease, hyperstimulation, fetal growth restriction, again, twins, or any other disease, and smoking and drugs. Question number 5, describe in detail what happens during the menstrual cycle. So there's a luteal phase and a follicular phase. So luteal phase will always be 14 days long. If it's shorter or longer, that's because of the follicular phase, and the cycle could be between 21 to 36 days. So starting off the follicular phase, so what happens is the hypothalamus releases gonadotropin-releasing hormone, which releases FSH and LH. So FSH stimulates the follicles to start developing the ovaries, and so when developing the cells around it, it releases estrogen. And this also stimulates the development of the endometrium, which then thins the cervical mucus, so then the sperm has an easier time penetrating through and reaches the egg. So in this case, negative feedback decreases the release of FSH and LH. So ovulation there is decreases estrogen when the egg will release, which then increases FSH and LH. So moving on to luteal phase, what happens is the follicle that released the egg turns into the corpus luteum. So corpus luteum releases progesterone, and if pregnant, the placenta will take over. If fertilized, so when conception does happen, the embryo secretes HCG, which keeps the corpus luteum alive, and this also tells you if you're pregnant or not. If not, the corpus luteum goes away and it stops producing estrogen and progesterone, which then stimulates more FSH, and the endometrium layer will start to break down, and then there you will get your period. What happens in the cycle during premenopause? So there is a decreased amount of estrogen, but there is an increased amount of FSH because the body is trying to compensate because you're not menstruating as much. So your periods could start to lengthen out and also skip some periods. And so the next question is, in addition, discuss the signs and symptoms of premenopause and the nursing considerations. So one of the nursing considerations here is that you're still fertile, so you want to take the precautions if you don't want to get pregnant, because you are a higher risk and your age is at a higher age bracket, so again, higher risk. So spontaneous abortions could happen, hypertensive disorders could happen, gestational diabetes, placental problems. And so the signs and symptoms can include, for perimenopause, is hot flashes, vaginal dryness, irregular periods, weaker bones, night sweats, sleeping disturbances, and mood changes. And so you want to encourage them to talk about their experience, because many women could feel like they are alone in this, and you want to normalize that. Again, you want to teach the contraceptive methods because they are fertile.